I'm going to talk about Williams syndrome, which is one of my favorite syndromes. I mean, I have a lot of favorite syndromes, but a really favorite syndrome. Over the years, I've probably seen 40 to 50 children with Williams syndrome. That doesn't include the parent association meetings I have attended, which there's usually 50 to 80 children with Down syndrome at those single meetings. But this goes back a long ways for me, and I'm going to give you a little bit of a review and then show you a lot of pictures. The history is interesting in and of itself. Fanconi, and that's the same Fanconi of Fanconi's anemia, first reported in 1952 a group of patients with idiopathic hypercalcemia of infancy. Now, he noted in that paper that some of them looked unusual, and some of those that looked unusual actually looked alike. So he was actually the first person to say that in his report. The reason he didn't go further was during this time in Europe, and particularly in England, they were giving large, actually huge doses of vitamin D to take care of the problem with rickets, nutritional rickets that was going through post-Second World War II. Actually, they actually made some of the patients sick. But in that group of patients that they were giving large doses, that they noticed large levels of calcium, were hidden in this group of patients with Williams syndrome. Williams actually first discussed this. These first two articles were both in cardiology journals, and he discussed the association of supravalvular aortic stenosis with high blood calcium levels. He also noted some other problems, including some facial features. Black and Carter sort of built on that and talked about aortic stenosis, actually supravalvular aortic stenosis, and that the faces of many of the children had severe infantile hypercalcemia. Once they stopped giving large doses of vitamin D to children, the frequency of hypercalcemia dropped to very low percentages. They didn't give a percentage in the literature that I've read, but they said almost zero. So the only thing that was left was the few rare cases of Williams syndrome, which in fact are not rare. And I say that because Williams syndrome patients have hypercalcemia sometimes. People have estimated up to 30% of the time in the first few months of life, and it goes away most of the time. But in many kids that weren't diagnosed with this syndrome, we don't know what the percentage of hypercalcemia was in those children. Buren is given credit for the formal article, and this is called the Williams-Buren syndrome. Because of it, he actually said that there was a recognizable phenotype. And then some 11 years later, Jones and Smith put it all together in a large package with a large number of patients and added other features to the syndrome. And then there was easily recognizable psychological or behavior component to the syndrome, which was to be further described. And then in the early 90s, the gene location on 7q11.23 was recognized to be the area where the gene for this, or genes, existed. This has been called a number of different names. Idiopathic hypercalcemia of infancy. For a long time it was known as idiopathic hypercalcemic supravalvular aortic stenosis. That's a tongue twister. That's why it eventually was named Williams syndrome or Williams-Buren syndrome. Some people felt that the children had an elf and facies syndrome. These were usually by people who'd never seen an elf, and no one's ever proven that such critters exist. Well, I'll show you this here. This is what people envision as being an elf with a sort of a bent forward face, long philtrum, somewhat sharp ears, particularly the superior helices. And this is a child with Williams syndrome that can mimic or was mimicked by people who drew elephant pictures. You will note some of the classic features of Williams syndrome. In this particular one, the large lips with the lower lip everted, the long distance between the nasal septum and the upper lip, and the fairly high set nose with only the lower 1/3 and the upper 1/3 being present. The puffiness around the eye area, and particularly over on the lateral borders. This particular child does not have epicanthal folds, which they often have, because the edema has ablated the epicanthal folds. The eyes are sometimes a little bit closely set, and then the nasal bridge is usually flat. The ears tend to be pointed in some of the children, but in most of the children they're not. The hair is pretty normal in some of the children. In a significant portion, however, it's curly and in disarray. And you'll see a lot of the kids will have hats on or their hair tied down so that it's manageable. It is a multi-system disorder. Its incidence has been estimated at the time I made the slide of 1 in 20,000, but it's now estimated to be 1 in 7,500 children. So it's a common syndrome. The ratio of male to females is equal. The incidence is the same in all ethnic and racial groups. And it's inherited as an autosomal dominant syndrome when it's inherited. The small head size is very mild. All the growth parameters are usually mildly or delayed or small, not severe. Microcephaly, for instance. We've talked about the puffiness around the eyes. The medial flare of the eyebrows is I rarely see it, so I don't consider it a major feature. Right, as a bridge, we talked about the nose, I said, we talked about the monophiltrum, large mouth, full cheeks, curly scalp hair is common, epicanthal fold is common, the malar bones or cheekbones are flat. The nasal tip is upturned. Some people feel that the nasal tip is a little bit bulbous. I really don't think so. The lips are full, particularly the lower one, and the mandible is often small. The face is more rounded in the infant and neonate, but tends to thin out over time.
Dr. Hall, is the growth retardation pre or postnatal?
It can be either. It has been reported to be, I think the percentage of prenatal growth retardation is in the range of 10 to 15%. So it can happen, but it doesn't have to be. And that's for height, weight, and head circumference.
So it can be acquired as well?
It can be acquired. And they have a lot of medical issues that might affect their growth as well. This is a child I saw at the University of Kentucky in the neonatal period in the NICU. He was recognized to have a heart problem, initially recognized to have supravalvular aortic stenosis. But even here, his diagnosis is highly suspect, with or without the supravalvular aortic stenosis being present. You can see the large lips, the eversion, you can see the high set nose, long philtrum. Ears are somewhat pointed, but not markedly so. At this point, and the quality of this picture is not good, you can't really see the very orbital puffiness. Here's the same child later. They're really cute kids. And they're cute in many different ways, but physically cute. You can see that there's some strabismus or interning of the eye, which is another feature that occurs about 30% of cases. He's smiling, so he's flattened out his lips a little bit, but you can still get the impression that the lower lip is large and inverted. You can still see somewhat mild elongation of the philtrum and residual flatness of the nasal bridge. Sometimes they will have a wide frontal area and a narrow bifrontal area, but that's not consistent, and sometimes it's a hard feature to be secure about when you're observing it. Here's the satellite hair, I call it. Remember, this is a connective tissue disorder in part because the elastin gene is the gene that's in the microdeletion section of the 7q11.23 deletion area. And there's a lot of manifestations of the elastogene defects, hernias, joint hypersensibility, cardiac defects, and in all those places, the elastogene is present. Again, we can see better now the periorbital puffiness, more lateral than central. You can get the idea of how high the nose is set on the face. Remember my 1/3 rule, nasal tip, lower 1/3, the middle 1/3, and then between the eyes, the upper 1/3. You can see here that there's no room for the middle 1/3, and that's also obvious here, but more dramatic here. You can see how prominent but simple the philtrum is. And again, the ears are not, in this case, pointed superiorly. The teeth are often small and laterally spaced. The irides, which you'll see in just a minute, are often stellate, and they're the easiest to see these stellate pattern when the eyes are a light color. Dark colored eyes, the stellate pattern's there, it's just more difficult to see. And I think that the stellate pattern is a higher frequency than 60%. They have hyperopia more as adults, and we talked about the periorbital swelling, which is probably not 100%, it's probably in the range of 90%. This is what the stellate pattern reflects, like it's almost like multiple webs of the iris. This is more of a blue-eyed individual with Williams syndrome, and this is a pretty, not specific, but useful marker feature, particularly in the young infant or neonate. Here's the puffiness around the superior orbital area, and it tends to loculate more laterally. This is an attempt to show the stellate irides, but here you can see irides in another patient that's stellate patterning. Again, we can repeat most of the features that you've seen in previous slides. Large mouth, full lips, with the small, widely spaced teeth. There's often malocclusion of the teeth. There's sometimes enamel hypoplasia. Sometimes the tooth morphology is abnormal. Occasionally there's hypodontia. And one of the characteristic things is that children have a deep, hoarse voice, which is not obvious initially, but becomes very obvious as they get older, and it's very common, and it's close to 100% frequency. Here's a collage of different individuals showing you all the features that we've shown you. Here you can see she has her hair tied down so it will be manageable. Here you see the stellate irides. Here's a child with a much broader face than most. It does show the small teeth and the periorbital swelling. This girl's older, so she's starting to thin out a little bit, but you can see the classic features, and note the stellate irides in this blue-eyed girl. She also has what I call satellite hair. This is a collage from early childhood and until I think she was 18 in this picture. Same girl. Her facial feature is a little bit more dramatic in the earlier pictures. Notice the hair. And as she gets older, the mom has to straighten the hair out with various techniques, so it can look different than what it normally looks like. She's a little bit more coarse, and her lips are a little bit larger, and even her upper lip in these pictures are large. The glasses are due to visual problems. They don't have a high frequency of cataracts, which you might expect with hypercalcemia, but they can have cataracts. But they're farsighted and sometimes require glasses. She has not yet developed obesity, but obesity occurs in 30 to 40% of the children as they get into late adolescence and young adulthood. Another collage, these are of different patients. just to illustrate the thinning of the face as they get older. This fellow's a character, you'll see him many times in some of the upcoming slides. The features are a little bit less dramatic than early on, but nevertheless, the features are there.
Do the teeth become more obvious later in life?
No, they're pretty obvious once the teeth start to erupt, and the adult teeth are probably better than the children's teeth. Here you see that he's got wide separation of his upper central and minor incisors. And this boy has a little bit more approximation of his teeth, but it's quite variable. I'm not going to repeat this slide of all the features and their frequencies. We have or will talk about all of those, but this is from a publication, which I can't remember which one. Murmurs are found in most of the individuals, and supravalvular aortic stenosis dominates the cardiac problem. This can be mild and never require intervention, or it can be life-threatening and or cause death. There's an increased frequency of pulmonic stenosis, and it's also supravalvular, much less frequent and not as significant from a cardiology standpoint. Other defects like VSDs and mitral valve prolapse, which is an occurrence often in connective tissue disorders, and patent ductus arteriosus have less frequency. They can have more complex heart problems. And they can be serious. So just because a Williams-looking child does not have any of these, but it has a heart problem, doesn't mean he doesn't have Williams. The musculoskeletal system is sort of a schizophrenic category for this disorder. Many of the Williams patients have joint limitations, almost half, and many of those with joint limitations, particularly at the elbow, cannot fully extend. And the majority of those are going to have fusion of the radial ulnar bones. And that's the reason they can't fully extend. But it's not the only reason. Even in the absence of radial ulnar fusion, they have trouble extending. And it's not terribly progressive outside of early childhood and early adolescence. These other features are just a reflection of poor connective tissue, and then inguinal hernias also, and umbilical hernias have an increased frequency.
So it's joint contractures, not laxity of joints.
I'm sorry?
It's not laxity of joints, it's contractures.
No, you can have both. It's a mixture, but the joint contractures tend to give the most significant orthopedic problems. I'll show you some kids. Some of the children actually look like they have connective tissue disorders with joint laxity. And they can look like cutis laxa and cutis hyperelastica, excuse me. Almost all of them have some degree of feeding difficulties, and this may be one of the problems with early failure to thrive. Remember, we said they're not necessarily small at birth, but sometimes they don't thrive well in the first year of life. That's complicated, of course, by the presence of colic. And as they get older, there's a very high frequency of constipation. This is more like in early childhood and up until early adolescence. But as they get older, constipation, like in the adult, is close to 100% frequency. And then in early infancy, vomiting is a problem. They don't usually have GI structural problems, but they can have diverticulitis along with their constipation, and they can have other problems on rare occasions with the GI tract, but not usually surgical related problems.
Could you relate that and the voice to like the hypercalcemia, or is that?
No, because remember, 70% don't have hypercalcemia, so it's not directly related to that. And the hypercalcemia usually goes away by 6 months of age in the ones that had it at birth. So there's much more of a complicated explanation or why they have some of these problems that you would think relate to hypercalcemia. But when you challenge them with calcium, whatever goes up under those circumstances goes up in these kids. So they still have the potential for hypercalcemia. And I've had a couple of kids who were over the age of 2 who had significant hypercalcemia, and they can get the complications like cataracts, like renal stones, and those type of things when that's present.
And does it come, I understand it comes back to the hypercalcemia when they're older?
It can, but I personally haven't seen it come back. Once it goes away, I've not seen it come back. But it can persist in some patients for quite a while. Okay, growth we've discussed. I'm not going to go through this, but they're not terribly short individuals. There's certainly a number that are well within normal limits, but they're smaller than their normal siblings. So you still see an adverse effect on growth in this condition, but it's usually not to a point of being abnormal or more than just mildly small. And here we get to the endocrine issues and the hypercalcemia. And as I said, there's a low frequency of documentation of the hypercalcemia. And as I said again, 25% or so have it, usually in the first 2 years of life. And then when they have a response to calcium loading, they respond as if they were deficient. And if you want to look at adults and the types of problems they have, there's been some large studies by Colleen Morris in Utah, and constipation, as noted before, is a high frequency problem. Obesity, significant. Peptic ulcer, cholelithiasis, diverticulitis, diabetes mellitus, and I don't know if this is associated with those that have obesity or not. Cardiovascular anomalies, of course, are still an issue for many of them. Joint limitations or contractures, recurrent urinary tract infections, and this is because some of the urinary tract problems can be due to bladder diverticuli, can be due to urethra being narrowed, or stones in the kidneys. They tend to prematurely age, and one of the features is gray hair, early onset. You can see them in some of the pictures I'll show you of the older ones, particularly where we're showing a parent affected and a child affected, that they're already gray and look much older than their chronological age. Here are 2 individuals with obesity. Even though this boy doesn't look obese in the face, he is obese, particularly truncal. This boy is obese throughout. I would say 90% of the pictures I'm showing you are verified cases by chromosome analysis. The others are just pure phenotype diagnosis. Here's some older individuals. They start to look a little bit different. They don't have as classic a face, and they vary. I don't know if this is the input from the parental phenotype background or not, but you can certainly see the face is narrow. These are 4 different individuals. You know, this boy has really good teeth, a little bit malaligned over here. Again, she's very dramatic for her age, sort of looks like one of the 1930 actresses with the long flowing hair and large lips. Notice that she still has a little bit of puffiness. She doesn't, he doesn't, he doesn't. So that puffiness goes away in time. And these are, again, just a different one. The teeth are not only widely spaced, remember they can be malformed, and here's a definite conical tooth. This boy has the hair that needs to be controlled. This girl too. It's said that blacks are more difficult to diagnose with this syndrome because some of the features of Williams syndrome can be found as normal in blacks. But it doesn't seem, in my experience, to be the case. And there's plenty of other racial and ethnic groups that have had equal number of cases of this syndrome, and they all still with Williams. The cocktail party personality is, people don't like to use this word, but it's a great descriptor of these kids. They're very social, they love to talk, they love to laugh, they love to be the center of interest. They have a very musical interest. They love music, so if you're in a room without music, they're still this way, but if you add music to the category, they even hype it up. They do have some reserve or distracting behavior. Their verbal abilities obviously are superior to their visual, spatial, and motor skills. They often have a good command of language, particularly for commonly used phrases and things that come on television. They often will repeat. They can have savant qualities. And these are not as dramatic as in some other conditions that we see, but they're still amazing. And member of the music, some of them play the piano extremely well. 60 Minutes had a 15-minute segment. Murray Schaefer interviewed about 5 of the Williams kids, and they had him in stitches. He totally lost it. He couldn't remember the questions he was going to ask because they were singing him left and right. And if you ever had the opportunity to see it, it came on maybe 10 years ago. If you know Williams syndrome, and you will after this lecture, whether you know it now, before or not, you'll see what they're doing to it. It's just fabulous. Here are the negative aspects of some of their behaviors. But overall, I think their interest in people and talking and observation and music overcome many of these. The gene identification occurred in 1993 and 4, and this explains the area of the 7 chromosome that's involved, and a very large percentage of patients who phenotypically have Williams syndrome will show a deletion. I think there's 26 to 28 genes in this area, the 7q11.23, and the elastin gene is the main gene in that grouping, but seemingly all the others, or most all the others, have some contribution to the phenotype. It's not always clear, and even when you're talking about the elastin gene itself, there are families that have just the elastin gene that just have supravalvular aortic stenosis, and then another member of the family will have that plus the facial features. So it's not as clear as people would like it to be. It is clear that in most cases, the larger the deletion involving that area, the more severe the phenotype and the abnormalities. But that's not always true. You can have a very large deletion and have a classic Williams syndrome patient. When we talk about larger deletion, we're including the 7q11.23 area, but larger deletions that include downstream or upstream occur. And those kids can be very difficult to diagnose because they have other features that can cause the phenotype to be hard to recognize. Most of the early cases, well, all the early cases were sporadic, but in the last, and now it would be 15 to 25 years, there's been a number of familial cases. No one's dealt too much with the twinning in this disorder, but there's 5 sets of twins in the literature, and I have 2 sets of twins in my experience. And so it's always an issue. Most of those are monozygotic twins, but there have been dizygotic twins reported as well. Morris has a good report of 2 familial instances from parent to child with Williams syndrome. And here they are. This father is 34 years of age, looks much older than that. This is his affected son. This is a mother who's 30 years of age, again, looks much older than that, and has an affected son. Another collage satellite here. This is the child who has very loose joints, looks like acute laxa. Patient would look with an open mouth. But again, this Williams syndrome, and here's the satellite here, better demonstrated. It's like this girl I had seen for like, I would say 4 years. Never entered my mind that she might have Williams syndrome during that time. Why, I'm not sure, except her phenotype looked much different than the normal phenotype that I would accept clinically. But as we did studies, we eventually found her to have a much larger deletion that involved the 7q.23, but also upstream deletion. And there have been a couple of reports with this phenotype involving that general deleted area. This is another patient who has a larger deletion. I wouldn't have considered Williams syndrome at all here. I doubt if I would here, but you can see that the patient would be a hard pickup for a diagnosis of Williams syndrome. This is Randy Quaid at a meet for individuals with handicaps. And you can see a Down syndrome, and look here, you see Williams syndrome. And Special Olympics involve a lot of Williams syndrome because they can be quite physically normal and active, and they're good runners. Here's a set of twins from Kentucky, one with Williams, one without. They unfortunately also both had cystic fibrosis. Here's a girl in Kentucky, or not in Kentucky, in Wisconsin, with very long, again, satellite hair, look how curly it is. And her favorite are horses, which is a common thing for the children with Williams syndrome to like.
The twins are not identical, right?
You're not identical, correct?
And they have both CF.
Yes. Really, really bad luck.
Yeah.
Now, this is a story, these are 2 unrelated children. He's not sitting on top of a TV set. These 2 children, I got a call from the mother of this child. They're both Irish, and they called me from Ireland, and said, our children, my child in this case, has been diagnosed with Williams syndrome. And she said, I went to the pediatrician to talk to him about it, and the cardiologist made the diagnosis. And he said, well, I don't know much about Williams syndrome. This is extremely rare. There's probably not more than 2 cases in all of Ireland. Well, I've forgotten what the Irish population was, but it was like 40 million. And I said, that's not possible. I said, what you need to do is go back to the cardiologist, find out any of the cases that they've diagnosed with Williams syndrome, and with the permission of the parents, contact them and try to set up some type of parent group, because they had no support. She knew the mother of this child, and so they contacted, and the 2 of these women set up the Irish Williams syndrome parent group. And when they got enough members, which took about a year to get 30 members, I came over and gave some talks, and I came back to a couple of their meetings over the years. Now they have 150 in their parent group. And I stayed overnight with this boy's parents at their house. And this boy and this girl both love to sing, love music. And at the parent group meetings, they would have a chorus that would sing songs. And it was quite remarkable. This is a American Journal of Medical Genetics. After I retired, they wanted a picture of me with a patient. Picked one of my favorite syndromes and patients and just pasted this on here for the sake of the slide. So, that's Williams syndrome as I know it.